Sure. So greetings, Madryn members. I think we'll probably have quite a few more folks joining us as people um, transition from one Zoom meeting to another, but I'm really happy to see some of you popping on. John, I thought I'd give you a little bit of context for what this actually is, the Madryn group that you're talking with. We started this group several years ago to try to begin to link independent living centers, which primarily serve people with disabilities, and area agency on aging, which primarily serve people who are aging, but also serve people who are disabilities. And funny enough, independent living centers also serve people who are aging with long-term disabilities. And that was a sweet spot that we thought was underserved in terms of agency staff working together to solve problems for this group of folks that are rapidly growing, surviving much longer, and kind of had needs that needed to be addressed that both groups needed to work together to figure out. So we did a research project with them. We started this research network, which is kind of similar to practice-based research networks, but it's our community-based research network. So we've linked so many agencies across the state of Missouri who have come together to try to solve these big problems that don't have a lot of money and a lot of resources to sort out how they can best serve the folks that come to their agencies. So you'll see lots of people on here that have roles in community agencies and the long-term supportive services network. So these are not folks that generally hang out in hospitals, and they're super valuable. These relationships are super valuable to us because it gives us as scientists the opportunity to hear real world problems, and then it gives so we can start to think about how to solve them. So that's the genesis of this, is they can tell us what's really happening and we can come up with real solutions to help them address those issues. So that's the context. And so we have some other folks that might be joining. I thought it would be useful to talk about what our network is all about. So you might, the reason that we asked you to come, John, is because we had Eric Lenz come and give a talk about depression, because a lot of the folks that we are serving that are in that overlap of aging with long-term disability, they have issues with pain, fatigue, and depression. But we also have a lot of folks that are interested in dementia and dementia care, and that became a really important topic. So one of the things we try to do is serve our network members by getting them the best evidence out there, and that's why we've invited you to talk about best evidence. The group was super interested in preclinical Alzheimer's disease and particularly disease-modifying drugs for Alzheimer's disease. And so they requested the expert in the field. And guys, I have delivered to you the #1 expert in the field with regard to Alzheimer's disease. So one of the benefits of being in St. Louis for me is that I was mentored by John Morris, who is the Harvey A. and Doris May Hacker-Friedman Distinguished Professor of Neurology at Washington University. And since 1998, he's been directing the Alzheimer's Disease Research Center, which became in 2010 the Knight Alzheimer's Disease Research Center. He is really known across the world for helping us begin to understand the process of the disease in its very, very early clinical stages. I call it clinical because I see little tiny things, but he calls it preclinical because there's not changes in memory and thinking in the earliest stages of Alzheimer's disease. We might see subtle things like maybe falls or weight loss or disturbances in sleep, but people, for the most part, are thinking pretty clearly. And it was really John and his team that helped us understand that. And this really led to our ability to develop drugs that can begin to address Alzheimer's disease. So he has also done some really other cool, important things that I think you all should know about. He was one of the early adopters of the idea that we have to include everybody in clinical trials, because if we don't have everybody, older adults, people of color, people with disabilities in clinical trials, we won't know if drugs impact those folks the same way they impact the people that are in trials. So he was one of the earliest in our field in Alzheimer's disease to bring in an African advisory board, which is now celebrating its 25th year at Washington University. So he's really committed to making sure that you all are included in trials, and that I think that is an important thing today that he might want to talk to you about. Also, he's one of the best mentors in the world. He has established a community of scholars, of students, of trainees. He's super engaged in helping us all understand Alzheimer's disease. So I feel really comfortable having you guys jump in and support this group in any way you can. He's one of the guys that I think makes sure that everybody's well respected and well treated. I don't always say that about all my colleagues, but I really believe in and trust in what he's doing. He's also really kind. He does have some bad dad jokes, so I'm just going to put that up there right now. So just beware that might happen during this session. But other than that, I didn't talk about all of the amazing papers and all those things that he's done. If you want those, I can share them. But he's a really important person, and I think he's the right guy to give us this talk today. So thanks, John, for coming. We really look forward to hearing what you have to say.
Great. Thank you, Susie, for very kind words. I'm really glad this is being recorded. I'm going to play your introduction back to my children and grandchildren. So, all right. Can everyone see the slides okay? Okay, great. Well, thanks so much, and thanks everyone for being here. It's an honor to present to the Missouri Aging and Disability Research Network. So, this is the Knight Alzheimer's Disease Research Center as of June of this year. It's a very large group, very interdisciplinary, and ranges from trainees to professors and beyond. So we are really benefiting from a wide range of experience and a wide range of talent and interests. We're very fortunate. It's one of the largest, if not the largest, Alzheimer's Disease Research Center in the country, and very honored to be part of it. So let's just begin at the beginning and with definitions and make sure we know what we're talking about. So dementia is a term describing a syndrome. It itself is not a disease, it's the manifestation of disease. And dementia means progressive decline in memory and other cognitive functions. And it's not just one's report that I'm losing my memory and I'm having difficulty. The degree of loss has to be sufficient to affect daily life. That is, people cannot carry out their normal activities at the level they once did. And we'll talk about this a little bit more. So this is a syndrome. It is caused by disease or etiology. The most common etiology is Alzheimer's disease. It's not the only etiology. And just by having Alzheimer's disease doesn't mean that an individual can't have other etiologies. As a matter of fact, we very often find that people who have Alzheimer's disease producing the dementia have other co-pathologies, including the telltale sign of Parkinson's disease, alpha-synuclein deposits or Lewy bodies, as well as cerebrovascular disease, strokes, and so forth. But there are many other potential causes of dementia besides Alzheimer's disease, dementia with Lewy bodies, we mentioned vascular dementia, frontotemporal dementia, and a whole host of others. So everyone with Alzheimer's disease will develop dementia, but not everyone with dementia will have Alzheimer's disease. Now, this is the slide that tries to depict what we understand as to how Alzheimer's disease proceeds in the brain. In the middle of this slide. And by the way, this is all at a microscopic level. This is way too small to be seen with the naked eye. So it's happening in the actual brain tissue itself. And in the middle, we see clumps of red colored protein. This is called amyloid beta or amyloid. Normally, amyloid is produced in the brain for whatever reason we have yet to discover, but it stays in the brain's fluid. It's soluble, so it's dissolved in the brain fluid. For some reason, possibly because its normal clearance mechanisms aren't working well, or in some cases because it's overproduced, there's too much of this amyloid protein in the brain's fluid. It turns out to be very sticky protein, so when there's a lot of it, these protein fragments tend to clump together and they come out of solution and get deposited in the actual brain tissue. They're no longer soluble, they're insoluble and in the brain itself. The brain's defense mechanisms decides this is abnormal, we have to get rid of it, and they try to do so, but the brain's defense mechanisms are not particularly smart, and they don't discriminate with their toxic response to this amyloid plaque to ensuring that it's only the plaque that gets the brunt of the toxic activities, but nearby brain tissue can be injured as well. As a matter of fact, that's what happens. And we see on the left of the slide a nucleus of a uh, brain cell called a neuron, and that neuron itself has lots of projections. And when the brain tries to get rid of the amyloid plaque, it also indiscriminately affects the brain cells, the neurons themselves. Those projections connect with other brain cells. That's how the brain works. Nerve cells send signals to other nerve cells. Where they come together is called a synapse. And the whole neuron, the whole nerve cell there is supported by an infrastructure that is made up of another protein called tau. And you see within the cell body here that the tau protein in blue is starting to become unstructured and fragmented and causes the brain, the nerve cell, the neuron to ultimately collapse because the normal structure cannot be preserved. So that's how we think brain cells die in Alzheimer's disease. Now, somehow, whatever the cause of Alzheimer's, if it's truly amyloid and perhaps it's a problem with clearing the normal amount of amyloid protein or it's overproduced, it is in some way related to age. We see here that right around age 60 or 65, we begin to see a notable increase in the number of individuals who are affected by Alzheimer's disease, and that number of individuals keeps increasing the older the age, so that by age 85 or 90, at least 25% of people are affected, and by age 95 to 100, something like 35 to 40% of people. Notice also that for reasons yet unknown, that women are more at risk for developing Alzheimer's disease, no matter what the age, than are men. But the main take-home message here is Alzheimer's disease is in some way an age-associated process. But also notice that not everyone who is 95 or 100 develops Alzheimer's disease. That is, I don't believe that Alzheimer's disease is inevitable with age. Something with age clearly plays a role, but age itself doesn't cause Alzheimer's disease because some people do not have it. As far as we know, there aren't any populations, no geographical locations that make people immune from getting Alzheimer's disease. Everyone is susceptible to Alzheimer's disease. And the world is is aging. People are living longer and longer. This is certainly true for the highly developed countries, but even the middle and low developed countries notice an increased number of individuals living to longer periods of life, and that means more people are getting Alzheimer's. So this is a steadily increasing problem. It is some of you, I'm sure, have had experience with taking care of an Alzheimer patient, and because it's a disease that goes on symptomatically for a period of 7 or more years, the individual requires increasing care, and thus it becomes a very expensive illness. The estimated cost of caring for Alzheimer patients in 2024 was $360 billion. It is a major killer. It's in the top 10 of all diseases that cause death. I actually think it's the third most common. It's not reported that way, but I think it is the third most common after heart disease and cancer. But it's the only illness in the top 10 causes of death for which we have no effective therapies, although I hope to give a bit of an update on that at the very end of this presentation. So it's a major problem in the field, and very costly to care for. So this depicts what happens in Alzheimer's disease. We've talked about the clumps of amyloid beta protein that start the Alzheimer's disease process. The clumps in the brain tissue itself are called the amyloid plaques. That's the sine qua non of Alzheimer's disease, to have an amyloid plaque. We also talked about the tau protein in the nerve cell body becoming affected by the brain's response to the amyloid plaque, so that the tau protein gets misaggregated and causes the nerve cell to die. We call that misaggregation of tau protein the neurofibrillary tangle. And we've already talked about this process causing both nerve cell death and the places where nerve cells communicate one with another, the synapse. Nerve cells and synapses are lost in Alzheimer's, hence the brain ceases to function. For some reason, the areas of the brain that are most highly developed in humans, the ones that give us our personality, our ability to use language, to remember, to reason, those are the areas that are most vulnerable, and that's why the symptoms appear in the way that they do. The loss of brain cells and synapses causes a loss of brain tissue. You can see a half brain here of somebody who died with Alzheimer's disease. It's much smaller than the other half brain that's someone who died without Alzheimer's. You can see that the Alzheimer brain is shrunken and the fluid spaces of the brain are enlarged and very clear. On the bottom right, you see a modern staining. Again, this is all under the microscope of an amyloid plaque, a dark clump of material that contains the amyloid beta protein, and then neurofibrillary tangles in black surrounding the nerve cell body, showing that that nerve cell is dying. In the upper corner, we see the original photomicrographs of plaques and tangles that were taken from the brain of that woman. And this occurred in 1905 and 1906. And the person who was doing the photomicrographs here, these are the original photomicrographs, was a man named Alzheimer. So the person in the inset is the first known Alzheimer patient. I'll tell you her story in just a minute, but I'm very certain that she is not the first person in the world to develop Alzheimer's disease. We can tell by going through literature that there are depictions of individuals who clearly had Alzheimer's dementia going back centuries, many centuries before this woman was the first known person with Alzheimer's disease. The story of the woman is that she came to an insane asylum in Frankfurt, Germany, when she was age 51. That's a photograph of her at the time that she was admitted to the insane asylum. And she died in the insane asylum at age 55. Professor Alzheimer obtained her brain and under the microscope made these photomicrographs. The reason she came to the insane asylum is her husband brought her there. And the story was this. A few years earlier, maybe as early as age 47, she began to develop loss of memory and thinking abilities. Of course, at first, this was quite mild, but as her memory and thinking loss accelerated, she was unable to do her usual activities. So the husband had to take over these activities for her. Of course, this all happened very gradually, but by the time that she was age 50, he was doing all of the shopping in the market, doing all of the cooking, doing all of the laundry. He could not leave her alone in their apartment when he would be engaged in these tasks because she would wander and no cell phone to try to track her to bring her back. So he had to take her with her. And as he went with her to say to the market, and he interacted with the shop women there to buy the produce and the meat for their meals. She accused him of having relations with these shop women. She was very jealous and thought that her husband was having affairs. She was particularly focused on a neighbor lady in the apartment building where they lived. She was convinced that the neighbor lady was out to steal her husband from her, and she would be up all night yelling at the lady next door terrible things about her, keeping the entire apartment building awake. And that's what ultimately led the husband to bring her to the insane asylum. Professor Alzheimer, she died, he got the photomicrographs. Professor Alzheimer went to a meeting in Germany, in Tübingen, Germany, in the year after she died, in 1907, and presented this case. It didn't make much of an impression upon the other attendees of the meeting, but 100 years later, then in 2007, they had a 100th anniversary of Professor Alzheimer's presentation. And I was very honored to be one of the invitees to go to Tübingen, went to the same lecture hall where Alzheimer presented this case, and I was able to give a lecture there 100 years later. I did meet a German neurologist at this meeting who had really researched Professor Alzheimer in this first known case of Alzheimer's disease, and he told me a very interesting follow-up story to this woman who died with the first known patient of Alzheimer's, and that is, after she died, of course, her husband was a widower. And then about a year or two later, he decided to get remarried, and he remarried that neighbor lady. So maybe she wasn't so wrong after all.
Her instincts were spot on.
Risk factors for Alzheimer's disease. We've already talked about increasing age, number one. Second, genes. There are some genes that some genetic causes of Alzheimer's that give almost 100% chance of getting Alzheimer's. One is Down syndrome. Down syndrome is also known as trisomy 21. Of course, we know that we all have two pairs of chromosomes, 1 to 23, and then the sex chromosomes. Chromosome 21, in Down syndrome, we get one chromosome 21 from our father, one chromosome 21 from our mother. But in Down syndrome, one of the parents, usually the mother, provides two sets of that chromosome 21. So that's why it's called trisomy 21. We have three rather than the norm. Down syndrome individuals have three rather than the normal two copies of chromosome 21. The reason this is important, it's on chromosome 21 that the gene that produces that amyloid beta protein is located. So this means from the time of conception, all individuals with Down syndrome are overproducing amyloid beta by 50% because they have that extra gene on that extra chromosome that's doing that. So by age 40, everyone with Down syndrome will have Alzheimer's disease, at least in their brain, because it's an overproduction of amyloid beta. Another cause of Alzheimer's disease that is almost entirely 100% sure to happen is there are three known genes listed there, APP, PSE1, PSCN2, that if inherited by an individual will cause Alzheimer's disease, deterministic. So every affected parent that carries a gene will have Alzheimer's disease. Usually the dementia occurs in the 40s, so early onset. And each offspring of that affected parent has a 50-50 chance of inheriting that deterministic gene mutation. If they inherit it, they too will get Alzheimer's disease at an early age. If they don't inherit it, they're at no more risk than anyone else. Well, Down syndrome is rare. These deterministic mutations are very rare. Less than 1% of everyone with Alzheimer's has this cause. So the gene contribution to people living with Alzheimer's disease who don't have Down syndrome, don't have these deterministic mutations, is a matter of risk genes. People can inherit genes that increase or decrease their risk of developing Alzheimer's. Not a cause of Alzheimer's, but makes them more or less susceptible. I give the example that I'm from, both my parents came from Northern Europe, and my skin pigmentation is really quite fair, very pale. I was a redhead before I had children, and my hair turned white. Uh, and that genetic disposition of pale skin, hypopigmentation, made me at great risk as a child of getting sunburned. Now, it didn't cause me to get sunburned. I had to go out into the sun to do that, but it put me at risk for doing that. And that's how we think are many genes that can increase our risk, but by themselves will not cause Alzheimer's. The one gene that we know the most about is called apolipoprotein E, or ApoE, and that is a known risk gene for Alzheimer's, but not a cause of Alzheimer's. We can also inherit protective genes. There are a few that have been noticed, including a variant of apolipoprotein E. But there are also a great interest in lifestyle factors that we might adopt to reduce risk for Alzheimer's disease. One is healthy diet, and great interest in things such as the Mediterranean diet, but heavy on vegetables, fruits, fish, and engaged lifestyle. So staying physically, socially, and mentally active. Whether these lifestyle factors really reduce risk, it's not 100% clear. They certainly will not harm us to adopt them, and many people do. But it's not the case that we know that they will prevent us from getting Alzheimer's disease. There are many people who have been marathon runners who end up developing Alzheimer's dementia. So it's not a foolproof way to do it. Won't hurt to do it, may help, and we advise our patients to do it. I put alcohol intake in there. I think that literature is being revisited. There used to be a idea that red wine in particular may be protective, but I don't recommend that to my patients. And social determinants of health. So we talked about staying mentally engaged, socially active, physically active. It's well known that the more education people have and the better quality of education that people have seems to be protective against Alzheimer's disease late in life. As a matter of fact, higher socioeconomic status is associated with less risk for Alzheimer's disease, and people who have less socioeconomic status and live in neighborhoods that are dangerous, crime, or have a high degree of pollutants and are discriminated against, have a higher risk of developing Alzheimer's disease in late life. So these, I think, are modifiable risk factors that we can try to address, improving the circumstances which we know increase the risk for Alzheimer's, and trying to augment the factors such as better and more education that decrease the risk for Alzheimer's. Susie mentioned that we think of Alzheimer's disease as a disease process of the brain that has two phases. The disease of the brain, as I've mentioned, is an ongoing loss of brain cells and their connections with other brain cells, synapses. The two major stages are the first, a silent stage, where the illness begins in the brain but has yet to cause enough nerve cell and synaptic damage that symptoms occur. So this silent phase or preclinical phase probably lasts 20 to 25 years when the brain is undergoing these changes but hasn't yet reached the threshold for brain failure to occur. And then the second stage is what we think about when we talk about Alzheimer's, the symptomatic stage of Alzheimer's, when the memory loss has begun. So we've already mentioned that we try to define or clinically diagnose symptomatic Alzheimer's disease when there's a decline in memory and thinking ability from what that person previously had attained. So they're losing memory and thinking relative to their past levels. And it goes very gradually, but ultimately is obvious to people and interferes with that person's daily life, with their daily function. The early stages are called incipient, prodromal, mild. The stages that progress later are called dementia, but it's all the same process of symptomatic Alzheimer's disease. So in our evaluation, we think of this continuous process that spans 30, maybe more years, where for the first 20 or so years, there's a clinically silent process of brain buildup of amyloid plaques and neurofibrillary tangles. Now we can depict those tangles and plaques by using sophisticated imaging, including PET imaging, and by examining the fluid that bathes the brain, the cerebral spinal fluid or CSF, for amyloid and tau. Ultimately, the damage is done and the synaptic and neuronal integrity is breached, and brain cell loss occurs. With brain cell loss comes the appearance of symptoms from very mild to mild. The course of Alzheimer's disease, on average, is 7 to 10 years. It is inevitably fatal. No one to date has survived Alzheimer's disease. But the symptomatic phase is really the end stage of the disease. Most people develop Alzheimer's disease in their 70s or 80s, which means the preclinical phase began back when they were in their 50s or early 60s. So we are increasingly trying to examine people in middle age to see if they are beginning this process so that ultimately we might devise ways to try to prevent symptomatic Alzheimer's disease. It's very difficult to tell the onset of Alzheimer's because this continuous process of nerve cell synaptic loss, it's hard to tell when symptoms really occur. So the origin of the symptomatic phase is hard to pinpoint the onset, but it usually is memory. Memory becomes impaired. Often the patient doesn't recognize it. It's really people who know them well can tell that they're having memory lapses, but it's hard to pinpoint the exact age. The disease always progresses. In the mild stage, people have clear memory deficit. They tend to repeat questions that have already been answered or tell the same stories. Now they, in addition to memory, have poor judgment, poor problem-solving abilities, and yet they look and act normal. And they're often still in the community. These individuals often are driving, they're voting in local and national elections, but they're not doing as well as they once did. The family will notice this, but they may, to a casual observer who doesn't know them, may look and act normal. They don't appear to be ill. The family will know because they know they're not the way they were. They aren't doing their activities at the same level they once did. But in general, the mild case to a stranger may be accepted as a normal person. By the next stage, the moderate stage, now these people are clearly impaired. They have very little memory, except perhaps for things that have been well rehearsed over their life, so from childhood and so forth, and no pretense of carrying out instrumental activities of daily living. They need help. And they often need help or at least supervision in basic activities of daily living. So dressing, grooming, bathing. The disease continues to progress. The end stage, they recognize no one other than themselves. They require total care. They're often bedridden, and death occurs usually in one of two ways. They lose the ability to eat and drink, so they die of inanition, or if they try to eat and drink, they aspirate, get pneumonia, and die. No one survives Alzheimer's. So back to healthy aging, because not everyone who gets older develops Alzheimer's. Often it's the diseases that occur as in association with aging that play a substantial role in the decline that many people attribute to age alone. So there still are people who believe that as one gets older, one inevitably is going to lose memory and thinking abilities. That's, I don't think, is true. I think that normal older adults without Alzheimer's disease are fully independent in their ability to think and to recall. One thing that does happen as a function of age is cerebral processing resources are decreased, so things take longer, but given time, a normal individual will come up with the proper solution to a problem. If there is cognitive decline, that's not aging, that is an underlying disease. Therapies for Alzheimer's disease, the first one that was approved by the Food and Drug Administration got approval in 1992, 1993, called Tacrin. It was a very difficult drug to use, and no one uses it now. But then in 1996, donepezil, followed by, which was known, the trade name is Aricept, followed by rivastigmine and galantamine, and then in 2003, memantine or Namenda. These drugs are all treating the symptoms of Alzheimer's disease. They do nothing to address the underlying brain disease that is causing nerve cells and synapses to die. Their degree of benefit was modest or is modest and doesn't occur with everyone. But in July of 2023 and the following year, July of 2024, two new drugs were approved by the FDA. Both of these are anti-amyloid antibodies. They're given by infusion. They get from the bloodstream into the brain tissue. If they see those amyloid plaques, they will adhere to those amyloid plaques and remove them from the brain. So how do we identify people who are eligible for these amyloid targeting treatments? Well, we need to know that they have amyloid in the brain. There's no reason to give these new drugs that target amyloid to people who don't have amyloid in the brain. So when we identify people who are eligible for these new treatments, there must be a way to know that amyloid is present in the brain. We can do that with that amyloid PET scan that I mentioned. Problem is that cost about $6,000. Recently, Medicare seems to be reimbursing, but for many years they did not. But more importantly, PET scans are not widely available. You need to go to a tertiary medical center that has all of the equipment and all of the staff and the radiologists to do this. So it's just not widely available. We can measure as I mentioned, the amyloid protein as well as the tau protein in the cerebral spinal fluid. That requires a spinal tap. So once again, certainly not widely available. You need skilled staff to do this, and many people have the idea that this is a totally invasive procedure and decline the opportunity. So it certainly is not widely available. But in the past 3 years now, we have blood biomarkers. So this is much more accessible, much more acceptable to people to have a blood test. And these are some of the blood tests that are being offered now. One of them has just recently received FDA approval for reimbursement. So this is a new era in diagnosis. We will know from examining the blood through these tests whether people have amyloid in the brain. And this is a way we're going to identify individuals who have early symptomatic Alzheimer's disease. They have Alzheimer's dementia. And we know through the blood test that positive blood test means they have amyloid in the brain. And hence they would be candidates for these new amyloid targeting treatments. This says that blood tests will gain broad acceptance and use in clinical care. I definitely believe that. And these new treatments are here, and they'll drive the need to make the blood-based diagnosis so we know that we want to treat these individuals ready for prime time. I'll show you in the upper right corner the removal of amyloid plaque by individuals who were in a clinical trial of the first drug, lecanemab. If the horizontal blue line are people given placebo, and you see they didn't have any reduction in their amyloid plaque over the length of the study, 1.5 years. But the people given lecanemab in yellow, they had amyloid plaque removed quite dramatically, at least 50% by 18 months. So amyloid plaque is definitely removed from the brain by these drugs. The bottom right tries to indicate it's worthwhile to do so. It helps patients because, again, in yellow, the individuals who were given the drug are declining. This is a CDR sum box. CDR SB is a measure of one's cognitive decline. And the people who are treated, the yellow group of individuals, are declining, but not at the same rate, at a lesser rate than are the people who were given the placebo drug. And the longer they were treated, the more the difference between the placebo people. So we think it does provide clinical benefit. Is it a cure for Alzheimer's? No. No, it is not. But it does seem to give clinical benefit to patients if we remove the amyloid plaque. So as I mentioned, these drugs now are available. This is just related to the first drug, lecanemab. We set up here at the School of Medicine our clinic to identify people who might be eligible for the treatment with the drug and trying to figure out what the resources are that we would need to give the infusions. It's very difficult. The infusions for this particular drug have to be every 2 weeks. And there are side effects of the drug. Of course, any drug has side effects, but in this case, the side effect requires monitoring by brain MRI scans, because here's what the side effect looks like. There can be swelling in the brain due to these drugs, and we try to do the serial brain MRIs and identify the swelling when it's just beginning, then hold the drug, don't give it anymore until the swelling goes away. If we were to not know that they had the swelling on these safety MRIs, we would keep giving the drug and the swelling might become large and injurious. There's another aspect of this. Sometimes it's not brain swelling that we see, but minor, very small hemorrhages in the brain called microhemorrhages. So we have to watch very carefully and those microhemorrhages appear on the safety MRIs as well. So individuals have to be carefully monitored with brain MRI to catch any potential side effect early, stop the treatment until the problem subsides, and then resume treatment. So we started out with many physicians and advanced practice nurses and coordinated with the hospital, with the pharmacy, with administration, with radiology, the infusion centers. It was a big deal. It is a big deal, and here's about the safety monitoring MRIs. Originally, some insurance companies, even though Medicare approved treatment with lecanemab, Medicare Advantage did not, and some private insurance carriers would not pay for the treatment. And the annual costs are substantial, $26,500. So here's what we need. It turns out that the earlier one initiates treatment in the course of symptomatic Alzheimer's disease, the better the response for the patient. So we identify Alzheimer's dementia as early in the course as possible. We get confirmation they have brain amyloid with biomarkers. Increasingly, I think it will be blood biomarkers. We get these MRIs and we give infusions every 2 weeks. So in our experience, the most common side effect were infusion reactions. About a third of the people get that. Usually can be treated. They're self-limited. Even Benadryl can be helpful. And 20% or so get those, either the brain swelling or the microhemorrhages that we detect by the MRI. So we stop the treatment in these individuals. Notice here that we stopped it at a time when 31 of 42 individuals with these MRI findings did not have any symptoms whatsoever. Of the 11 people who did have symptoms, most were mildly symptomatic, but 2 were moderately symptomatic, and we hospitalized them to make sure that their brain swelling or brain hemorrhage would recover. So we found that initiating amyloid targeting therapies is doable, but it requires lots of resources, many clinicians, the help of many people in the hospital system to provide this. We have to find individuals who are eligible, and so far I think we've had 400 plus individuals treated with these drugs. I think 2 are African American or Black. And people have to be prepared to pay cost if their insurance company doesn't cover it. So have to be affluent. We found side effects of these drugs in about 20% of individuals. Fortunately, the side effects, 75% were asymptomatic, and only 2 had to be treated for that. We don't know how long to continue treatment with the drug, and how to measure whether people are still getting benefit is unknown. Let me come back here. All of these are problems, and we're addressing them and continue to learn and get better educated. But it's the first time we've had treatments that are disease modifying, remove amyloid plaque, and seem to be associated with clinical benefit. So with the advent of treatments, of these new treatments, and with a new way to diagnose Alzheimer's disease through the blood, I think we are on the footsteps of a new era in Alzheimer's disease. We'll get better ways to make the diagnosis. We'll get better drugs than these, and hopefully we'll get better benefit for patients. So we're cautiously optimistic about the future. And I thank you for your attention. I'm happy to answer any questions you may have.
Thank you, John. That was fantastic. Please go ahead and come up, open up. We'll open up questions if you want to unmute and turn on your video. We have a few minutes to, I know you guys have lots of great questions.
I have a question, Dr. Morris.
Please.
So let's say we start noticing changes in a family member or a loved one and think maybe this is the start of the development of Alzheimer's. What do we do at that moment? Like, what is step one, I guess?
Yeah, so good question. Thank you. I would normally say, please have the patient seen by the primary care physician. I will also say that most primary care physicians are way too busy to make the diagnosis. They have too little time to be with the patient, much less to interview the family who has noticed the change. And most patients, if you ask them, how's your memory? They'll say fine. They're unaware. Matter of fact, I've had very few of my patients who have called for the appointment. It's almost always the family that makes the call. So if the primary care physician doesn't make the diagnosis, then I think you ask for a referral to a memory specialist. And again, that's a matter, unfortunately, of accessibility and resources. So it's not for everybody. There just aren't enough memory specialists around to do this work. So we hope that the advent of blood tests, that's something primary care physicians could conceivably do. I mean, for people 65 and older, are supposed to get an annual Medicare evaluation. You get your hemoglobin A1C to see where you are with diabetes, and your serum creatinine to see how your kidney function is doing. I can see getting a blood test for Alzheimer's. I mean, that's not here now, but I can see that happening. And maybe then, if we have these drugs or even better drugs, it makes it worthwhile for even primary care physicians to make the diagnosis. But right at this point, if you start with the PCP, if you don't get an answer, then really try to find a specialist, because the sooner it's diagnosed and the person, if they're eligible for and want to get treatment, the earlier treatment starts, the better the result.
I have a follow-up question. Oh, sorry, Shardana. Did you have more?
Let's go to Deb and then we'll go to Missy.
Sure, sounds good.
Go ahead, Deb.
Miss Deb? Okay. Yes, Dr. Morris, I was wondering, and maybe I missed it, I apologize if I did, but I was wondering if the memory decline focuses on certain times, like is it more recent or numbers versus names and faces? Is there any data there?
Yes, yes. Thank you for that question. Yes, it is recent memory. It is recent memory. That's what happens first. So uh, it is really very. What did I have for dinner last night?
Uh-huh.
Or who did we go out to see the movie with last week? And so it's recent events happen first.
Yeah.
Uh, I mentioned, it could be forgetting conversations. So forgetting, I already told my wife that I'm going to be late for dinner, so I tell her again.
Mhm.
Or I ask her a question, she gives me the answer, and I forget it, and I ask the same
Yeah.
question again. Or I put things down. I put my car keys down and forget where I put them. Or so now, some of this happens to all of us, right? But
Yeah.
it's a change from the way the person once was. And early on, it's hard because it's sporadic. We don't know, but it always gets worse. So if you notice that, I think it's worthwhile getting evaluated. And,
Mhm.
and I've also been, I don't know if Susie has had this experience too, with some people who have clear Alzheimer's dementia. Some things they can remember very well. And sometimes people who, for example, grew up playing the piano, they can sit down at a piano even though they have mild to moderate dementia and play as well as they once did. They remember it from all those decades ago. So you're quite right. It's recent memory first.
Okay. Just quick follow-up. Is it also uh, that older memories are more prominent,
Just better rehearsed.
just better rehearsed?
But yeah, I mean,
So,
we've rehearsed those old memories
okay.
over and over again for all of our life. So that's why they're the last to
Okay.
be affected.
Okay. Thank you.
No worries, Annalisa. We'll keep recording. So Missy, on to you. Thanks, Deb.
Thanks. So my question is sort of a follow-up to Shardana's question. So you mentioned like if the primary care provider, you may need to ask for a referral to a memory care specialist. What advice do you have for people in rural areas where this is just this, we come across this with my parents all the time that live in rural Missouri, just trying to get them, they have mobility issues. Is there any, like, what advice do you have for that? Are there
Yeah,
telehealth appointments or other creative solutions there?
I wish I could help. I can't. It is clearly a huge issue of access, resources and access. And Susie mentioned that we're interested in trying to take our research findings that we have developed from our research volunteers who are mostly white and well off and healthy and try to go to the community where people aren't so healthy or well off and are and have other uh, racial identities or ethnicities. So we're trying to move out into the St. Louis community, but we also need to move out into rural areas because the access there is, as you point out, is almost maybe it is non-existent. So I don't have an answer. I wish I did, but I don't. It's an unmet but very important need. And we here at the Knight Alzheimer's Center clearly have committed to the St. Louis area community, but we realize that our community is surrounded by tremendous rural counties and populations, and we need to move there too. So thank you for reinforcing that need.
Thank you. Appreciate it.
Well, John, thank you for coming today. Do you have any, like, what's coming up? Are there any opportunities for our research network to interact with the Night ADRC or to have, collaborations that you see in the future?
Well, I would be, if any of you have connections to our St. Louis City population or underrepresented populations of St. Louis City or to rural communities, I'd love to talk more and plan more about how we can extrapolate what we're learning here to the broader population, be much more representative than we are here at the School of Medicine. So I'd be happy to do that. And I would be entertain any suggestions that any of you might have as to other ideas for us to become more welcoming to the population at large beyond the Washington University School of Medicine.
I think that's awesome. So what we'll do maybe then, Shardana, is we'll make sure everybody gets a copy of this video, and then we'll query the research network to see if anybody would like to do a subgroup to meet with Dr. Morris and his team to kind of discuss potential opportunities to collaborate. Does that sound reasonable, John, to you?
That'd be perfect.
Awesome. Fantastic.
Sounds great. And if you joined a little later, go ahead and just put your information in the chat and where you're from. I noticed a few new people to pop on about halfway through. So we'd love to just keep track of who is here.
Well, wait a minute, Shardana. If people join later, I want them all to listen to Susie's introduction of me.
That's right.
I will send that on.
We have this recorded and we're going to send the link to everybody. So I'll even send it to your grandkids. So
Great.
All right, John, thanks a million. Everyone, thanks for showing up. Hope this was what you guys wanted and looking forward to building some collaborations with the Night ADRC.
Great. Thank you, everyone.
thank
Take
you.
care, guys.